helping you guys understand a very rare condition that I have called ADEM, or ADEM. So that's what we're going to be talking about today. So let's get to it. All right, so a little bit about me. My name's Ian, and I have a bachelor's degree in mechanical engineering, but I primarily work as a public speaker and as an author. And so I do go different places and speak, but usually to elementary school kids. So you guys are a little bit older than that. But so yeah, I do speak in front of people quite often. But regarding my condition, it's called ADEM, and I was diagnosed with it when I was 11 years old. It came on very suddenly, no warning whatsoever. I woke up with like a pain in my neck. Was September 25th, 2005. Woke up with a pain in my neck, and literally within probably 90 minutes of waking up to the time that it came on in full, I was literally just shopping like at Meijer, right by our house, and I went to go turn my head to like say something to my dad, and my arm went completely paralyzed, like just instantly. And within minutes, my right leg went paralyzed, started losing control of my eyes, started losing control of my left arm, left leg. Yeah, it was really rapid, really spontaneous. I had no prior history. Basically, before that day, I was very healthy, very active. The day before that, I just played a soccer game. I was going to go ride my bike that morning. I used to do gymnastics, martial arts, all sorts of different things. So it was very unexpected. So you might be wondering a little bit, what is ADEM? So ADEM, it stands for acute disseminated encephalomyelitis. And basically what that means is acute, so rapid onset, disseminated, widespread, encephalo of the brain and spinal cord, myelitis, and inflammation of the myelin sheath. So basically you have a rapid onset of demyelination and encephalopathy. Mine was at the brainstem level. With many of these cases, they can be sometimes at the cerebrum, or some of them are at the brainstem, some of them are at the spinal cord, some of them are at all three. And there's a lot of differences in severity. But it's a very rare condition. According to the Cleveland Clinic, I think they measure it around 1 in 250,000. So it's fairly rare. It used to be a lot more rare before, because they've gotten better at diagnosing it. I believe like when this first happened to me, I mean almost 20 years ago, it'll be 20 years ago in September. I want to say they measured it like it was around like 1 in 2 million or something like that. So I don't know if it's become way more common or they've just become way better at diagnosing it. But yeah, it's an autoimmune condition. But it's unlike some of the other autoimmune conditions, like say MS, it's monophasic. So that means that it has one flare-up period and then no further. So it's almost like an injury, and that like you have like an initial you get hit with it, and then you just deal with it. I'll get into the treatment part of it because that can make a really big difference. But yeah. And then I have a diagram there of the myelin sheath. So like myelin is a fatty coating that protects your nerves, and it helps ensure that nerve signals go to where they need to go. And so like when your immune system targets it and strips it, it's like a wire stripper. And so like you can imagine that all of a sudden signals aren't going where they need to go. So you don't usually get full paralysis. You can get full paralysis from it, but it's usually more what they call like paresis, which is like just very much impaired motor function, but not total paralysis. So yeah, I would be what they call quadriparetic. So I have weakness in all 4 limbs, but I'm not paralyzed in all 4 limbs. So, but a lot of times I'll just say quadriplegic because no one knows what quadriparetic is. So, yeah. So symptoms. All right. So as I was saying, it comes on with no warning. That's why it's acute. So you can get things like muscle weakness, sometimes paralysis. You can have seizures. You get what they call ataxia, which is like a loss of coordination. So like you're not able to coordinate muscle movements. You can slip into a coma. I was in a coma for 3 days. You can actually have what they call locked-in syndrome, which can happen if it's specifically at the brainstem level, where basically what locked-in syndrome is like you are completely conscious, but you cannot move any of your muscles, not from your eyes to your toes. Like it's like being catatonic but awake, basically. It's terrifying. And with the locked-in syndrome, like that's kind of a rare complication of it, but when it happens, like it's no guarantee when you'll come out of that. Same with the coma, there's no guarantee when you'll come out of that. And then also, like, I don't know if anyone can see it, but like usually there's, it affects your eyes because it happens, a lot of times there's involvement at the optical nerve level. And so like, I don't know if you guys can see it, but like I have what they call nystagmus. And so like when this first happened, that was one of the first signs that was happening, is all of a sudden my eyes just started doing this uncontrollably. And actually I was borderline blind for probably close to 4 months after this happened. I had no control of my eyes whatsoever. Also sensitivity to light. So yeah. And then obviously like with the lack of motor control, you also get like impairs your breathing. So like I have like diaphragmatic weakness, impaired like bladder bowel responses you have. And you can have impaired facial and swallowing function, which I don't really have as much anymore, but I used to. And then like, yeah, it causes like terrible nausea too. Like, you can't stop throwing up because you get like spasms basically in your digestive tract. Just mess you up. So it's pretty brutal. It's actually very brutal. And so, yeah, it's very, how would I say this? It's very terrifying because like you have no idea what's happening, and usually the doctors don't either. So it's a bad combo. But yeah, so here's some ADEM statistics. So it's more common in males than females by like 30% or something like that. So like 65% of cases happen in males over females. And it usually happens in like adolescents. So like people under the, like 85% cases are in people under the age of 18. So it's primarily a childhood disease, primarily males. And what was I going to say about that? I was going to say there's also, I think it's on the next slide, there's some seasonal variation with it. Something like, what is it? Like something like 50% of all cases happen in either the spring or the winter. So like there's some seasonal variation with it as well. And yeah, so, and I already said like 80% of cases happen in people under the age of 18. I did read that the oldest person ever diagnosed with ADEM was 86, which is very, very uncommon. Usually if something like this happens later in life, it's MS. But you can have it later in life. It's just very unusual. Oh, I forgot to mention, I think, that last slide about what causes it. So yeah, something like 85% of cases happen within 30 days after an infection. So, or an immunization. So anything that can trigger your immune system can potentially trigger this. Basically what happens is like there's a catalyst and your body like starts to attack that, but then it starts to get revved up and starts attacking other things, and you know, it targets myelin specifically. So yeah, it's but yeah, so it's definitely like in my case, I had an ear infection about 3.5 weeks prior to this. So that helped them kind of figure out what it was because of how soon before the attack it was. So there's like I don't know if you want to call it like a build-up period, but even when you have that infection, like you're not having ADEM symptoms. Like you can, it's basically like dormant for the weeks following until it just snaps, you know. Oops. Okay, so now we're at the diagnosis part. So it's very difficult to diagnose ADEM. You can't actually diagnose it with like a specific, there isn't a specific test that tells you like this is definitively ADEM. All they can do is eliminate everything else. So they can eliminate you have MS. They can eliminate you have NMO. They can eliminate you had a brainstem stroke. They can eliminate that you had TM. They can eliminate that you had lupus, right? So there's a lot of conditions that look like ADM, but they have some slight variations. And all they can basically do is eliminate those. And if you're not one of those, you're ADEM. So, which doesn't give you great confidence, because it's just kind of like, well, it's just process of elimination. But the way that they primarily diagnose it is through, they use like MRI with contrast. And so, and then they also will use like a lumbar puncture to look for demyelination. I was going to say, also your diagnosis of ADM is slightly dependent on like prior histories. So like I said, like if you had an infection within like that 30 to 40 day window, or your age, like if you're, younger versus like an adult, because like MS doesn't usually occur in children, but ADM does. So there's some other clues they can use to kind of piece it together. And then for the methodology, like I was saying, they use MRI, and there's some kind of unique characteristics of ADEM lesions. So ADEM lesions, you'll notice them a lot in the white matter. So more like isolating the myelin sheath, and also they're usually what's called like asymmetric. So like they're like irregularly shaped, and they're bilateral. So you'll notice them on both sides. So like a lot of times with ADM, you'll see lesions on the left and right, and they're irregularly shaped. Where like with MS, like it can all be on one side, or it can be like really weird patterns. And so like there's a specific pattern that they can kind of look for too with MRI scans. And something that's a fairly recent development is they're using blood tests to diagnose certain forms of ADEM, because there's variations within ADEM. Like ADEM is kind of an umbrella term, but like there's this one form of ADEM that can be it can be somewhat not recurring, but it's got more like a genetic meaning to it. And they test for something called anti-MOG. So it's like an antibody that is present that like specifically attacks myelin protein. So there's like a protein that codes the myelin called MOG. And so like if you have certain antibodies that target that protein, like that can also be a sign that you have ADM. And you'll have elevated C-reactive protein levels, which just means you have more inflammation in your body. But you can have elevated C-reactive protein levels with a lot of different things, so that's not a dead giveaway, but it can contribute to it. So yeah. So for treatments, you basically have 3 options, and usually they'll do 2 of them together, and the third one is usually staggered. So IVIG is intravenous immunoglobulin. So it's basically an infusion of like immune antibodies. It like replaces your immune system, and it makes you feel really sick when you're getting it. I actually had several rounds of it. I got mine too late. With treatment, if they get you the correct treatment very early, like you'll recover fully. But there's like a 2-week window to do that. So, if you don't get it in that time, it basically each passing week it gets worse that they miss it, and it'll get to the point where if they miss it too long, that a lot of these treatments don't do that much. But they can still help even months afterwards. But like I said, it's diminishing returns, afterwards. And then also IV steroids to fight the inflammation. So you get part of ADEM is the encephalomyelitis part. So the encephal part, that's the encephalopathy. So it's like swelling of the brain. So the IV steroids, they help fight swelling, and they just help fight that like inflammation response. So they help kind of do some damage control in the early days. So like if they get you IV steroids like day 1, like it'll literally like stop it in its tracks. So yeah, IV steroids are super powerful against it. And then there's also plasmapheresis, which I've had as well, and that's basically just like it's similar to like a blood infusion where they take out your plasma, like they take out all of your plasma and they spin it and they put it back into you. So, but it helps remove toxins out of your body that can like trigger like immune reactions. So it helps kind of like restructure your immune system. So yeah, those are basically the 3 frontline treatments for ADEM. And so like prognosis, it varies widely, like very widely. So if it, like I was saying, if it's diagnosed quickly and it's treated correctly, not just diagnosed but also treated correctly within that 2-week window, you'll make a full recovery. So there's a lot to that. If they miss it, which a lot of times they do, you're going to have long-term issues. If it's a really severe case, like AHLE, which stands for acute hemorrhagic leukoencephalitis, if you have that version of ADEM, 50% of those people die within 7 days after getting it. But only about 3 or 4% of ADEM cases are that. So that's a very lethal variant of ADEM. And why it's lethal is because it basically the immune system attacks the brain like so much that like it causes bleeding. So like you get pretty severe bleeding, and it's usually at the brainstem level. So like it looks very similar to like a brainstem stroke, but it's very lethal. The version I had is probably closest to AHLE because I had a lot of the symptoms are more in line with that because I had the coma. I had more diaphragmatic distress, really severe headache. The more severe your headache is with ADEM, that's a sign that you have more encephalopathy, you have more inflammation. So the more severe the headache, it can also be a sign of what they call like intracranial pressure. So like your cerebral spinal fluid is building up in your skull and pushing on your brain. So like basically the more severe the headache and the more severe the diaphragmatic suppression, the more lethal it is. And I had both of those, so yeah. Yeah, but like 50% of, if you're just lumping all ADEM cases together, like 50% of them make a full recovery. And then the other 50% are somewhere in the spectrum of me, so. And then for residual effects of ADEM, well, muscle weakness, impaired muscle coordination, and this can affect everything from like your limbs, your eyes, your diaphragm, your bladder, your bowel, like literally all muscles, like, because I said it can be at the brainstem level, so literally, like everything below that point is fair game. I deal with muscle spasms and like increased muscle tone. So like you'll notice like I have extensor tone, so like my neck always wants to go back. And that's in part due, in my case, to compensatory patterns. So like when you have impaired like motor neuron function, basically like your body recruits muscles to make up for those weak muscles. So like in my case, my diaphragm is weak. So like my body recruits my neck and my shoulders to help like with my breathing, which contributes to the extensor tone. So it's kind of like one of my goals with physical therapy is to like break some of these tone patterns, but at the same time like I kind of rely on them to live. So it's kind of like so yeah, extensor tone, and like I said, the higher up it is, the more chance you're going to have the extensor tone patterns. I think I mentioned TM, but TM stands for transverse myelinitis. It's also a variation of ADEM, and it's usually like at the thoracic or lower. And that causes full paralysis, but like it's usually only like half your body. So yeah, ADEM doesn't cause full paralysis usually, but it's like affects your whole body. TM causes paralysis, but it's only half your body. So it's like, I don't know which one's worse. And then also you get increased. So I don't think I mentioned it earlier, but like in my case, and in a lot of ADEM cases, you get altered sensation. So mine is very abnormal because I had hypersensation. So like when this happened, like basically like everything like felt like I was ripping my skin off. Like I just like it was like my nerves were raw, basically. So I had like hypersensation, and I had hypersensation for probably close to 2.5 years after this happened. My sensation remained elevated, like severely elevated. But in a lot of ADEM cases, I have reduced sensation or numbness or tingling. So that can be a residual effect of ADEM. And then also like difficulty with concentrating, depression, and PTSD, which are psychological effects of ADM just because of the way it comes on. You don't feel safe anymore because you're just like, well, every pain in your neck could be, death. So that's, yeah, you don't feel safe after that. So psychologically, it's terrifying, I guess, to say the least. And so now the part you guys probably care about the most, the PT side, the physical therapy stuff. So it's really kind of hard to describe PT for ADEM because every case is very different. And it's like such a weird disease that I don't even call it a disease. I call it an injury because it's like a one-time event and then you deal with it. When I say injury, people are like, "Oh, you were in a car accident?" I'm like, no. like, quick side note: when you have a rare condition, like people ask you about it, you never know, like if you should be like really upfront about it or like try to kind of like dumb it down, because if you dumb it down, they'll ask you a follow-up. They're like, "So what's that?" And then you end up telling them the whole thing, like after like 5 what's that. And so if you dumb it down, you get there anyway. But if you tell them it all up front, they're like so intimidated they go away. And so so it's kind of like you never know if you should fire hose them or if you should just kind of like incrementally do it. And so I still haven't figured that one out. I'm still like, because I'm like, they're like, "Oh, what happened to you?" I'm like, an injury. They're like, "You were hit by a car?" I'm like, "No." They're like, "You motorcycle?" "No." It's like, they're like, "Well, what is it?" I'm like, "My body." They're like, "Oh, that's a disease." I'm like, "No, because it happens once." They're like, "Oh." So it's this weird thing that I still deal with. So, I'm still sorting it out all these years later. But like, yeah, so there's no one size fits all approach for ADEM. Basically, every case is a little bit different, and PT for it is kind of frustrating because like you'll go places and they'll start out like targeting what you need, but for insurance reasons, they have to like basically bill it as something else because like a lot of times like insurance doesn't even like know what this is. Like that's how like unusual it is. And so like I can't tell you how many times like I've gone to physical therapy and like they've started working on like trying to break one of my tone patterns or something, and then they go to some more generic goal because like it looks better for insurance purposes. And so it's very frustrating because it's like basically if you want to get therapy, you have to almost like accept something that like isn't really working for you, because otherwise they're like, what is this, and so because everything's coded, in the insurance industry. So, basically the more common it is and the kind of like the easier it is to bill it, like the better. The harder it is to explain, the harder it is to justify payment. And that's just kind of how it goes. So yeah, it's kind of a constant battle between getting something and kind of like getting what you actually need. So yeah, and then what else was I going to say? So a lot of times what they revert to, because there isn't like an actual ADEM protocol, is it's usually some combination of what they would do for a spinal cord injury and for MS. So it's usually like some cross between those kind of things. And so because ADEM, the weird thing about it is it's very similar in a lot of ways to a spinal cord injury. So like it has a lot of overlap with a spinal cord injury, but not quite. It has a lot of overlap with MS, but not quite. So it's just everything's kind of like not quite. So there's no like they haven't really seemed to figure out exactly what works best for it yet. So I've done a lot of trial and error with it. I've been to, oh boy, I've probably been to close to 20 different therapy places over the course of the years. I used to go to the Kennedy Krieger Institute for Spinal Cord Injuries, which is out in Baltimore, Maryland. It's connected to Johns Hopkins, and I went out there like 17 different times, and their program had me doing intense physical therapy for 5 hours a day, 5 days a week, for 6 weeks at a time. And it was actually the first place that I started being able to like walk again, because you guys see it a little bit. I actually have some video of me walking. I use a walker and leg braces. You see my leg braces right there. They're AFOs. But yeah, that was the first place I actually started walking. Their protocol, like they were treating me like I was just a straight up spinal cord injury. And it worked. I mean, it got me moving. It was a lot of electrical stimulation stuff. And that's what it took to kind of wake my muscles up and, get me able to do stuff again. That and a lot of aquatic therapy was really helpful too. Because when you're in the water, the buoyancy, it helps you like, so how would I explain this? Like with tone patterns, like gravity is the enemy with tone patterns, because basically when you're resisting gravity, like a lot of different muscles have to activate, like for your balance and all that stuff. And with demyelination, signals aren't going where they need to go. So basically the more muscles are being recruited, right, the harder it is to like isolate things. And so like in a gravity eliminated kind of scenario, you get a lot more muscle isolation, you get a lot more control. So like when I'm in the water, like chest deep, I can just walk. Like I can literally like walk and stuff. So, everyone always complains about global warming. I'm like, I can't wait for the world to be like 4 feet underwater. Like I'll be able to walk everywhere. Like, I'm gonna be like Dr. Evil. I'm gonna get that laser beam, melt those ice caps. But that's why I got my engineering degree after all. So I can flood the world and walk again. But like, all jokes aside. But yeah, aquatic therapy helps a lot. For ADM, I will say this, it's very temperature dependent. So remember how I was mentioning the sensation stuff? So with sensation comes muscle reflexes. And so like with really cold water, normal people just shiver a little. But for people like me, it's like every muscle fiber in your body just like contracts 100%. And so like you get in cold water and you're rigid. Like you literally just go rigid. So I have to go in like basically hot water to like, so when I say I need to flood the world, I also need the water to be warm. It needs to be bath water pretty much, or really hot tub water. And then also, what else was I going to say? My goal with my physical therapy is to promote remyelination. So there's a lot of debate over if myelin actually really truly grows back or not. Now the myelin that's like, they call it distal, like your distal myelin that's like, say like on your muscles, like on your hand, like your arms and your legs, like there's myelin at that level. And that like the more exercises you do, like high repetition, like that myelinates, like that you get more myelin there. But like at the spinal cord level or like at the brain level, like that myelin's a little bit different. And so it's not entirely, like it's somewhat up for debate if like high repetition exercises triggers remyelination and that. But I do high repetition exercise, so I usually keep weights kind of low and I just rep them out until like I can't go anymore. Or I'll do a lot of isometrics. So like isometrics help with the signal. So the longer you hold a muscle, basically like that signal like will get stronger over time. So my protocol involves a lot of like isometrics, a lot of high repetition exercises. And with other people, I've known that I've never met anyone else that has ADEM. I've met people who have TM, and they do similar things. So that seems to be kind of like a normal thing for that. Also, another thing that helps a lot with ADM is PNF stretching. So basically like that contract, relax kind of stretching, like it breaks up tone patterns quite nicely. You know about that. So, yeah, and then what else was I going to say? Also, yeah, promoting flexibility, just because you get so much muscle stiffness with ADEM, just promoting that flexibility. Because like in my case, I'm not weak. Like my muscles are actually fairly strong. I just lack coordination. So like with someone who has paralysis where like the nerve is severed, like there's no motor control at all. Like it's just like the signal's dead. In my case, I have an incomplete signal, or I have a signal that's just going other places. So I have an incomplete signal. And so like a lot of times I'm fighting my own body. So like, like for instance, like when I go to like contract my bicep, after a certain point, my tricep will turn on. So I'm no longer just fighting gravity, I'm fighting my tricep. So I'm actually fighting my own body to like move. And so like, and that's because I'm getting overlap of muscle signals. And so, yeah, it's basically like with ADEM, you're not just trying to strengthen the body, but you're trying to actually like break up those patterns so that they can use the strength they actually have. Because otherwise they're just fighting themselves. which will make you strong, but not, you know, that was, I don't know if you guys are familiar with Charles Atlas, but he was a bodybuilder from the 1950s, and his whole method of building muscle revolved around using your body's own resistance. So like he would like flex his bicep and like resist it with his tricep. So like his other tricep like this, so he'd like do this. So he used his own body's resistance to basically build muscle. And that's basically what's happening all the time in someone who has ADEM. You're just fighting your own muscles all the time, which, like I said, like you actually will gain a lot of strength. It's just not coordinated strength, which is basically useless. So yeah, it's, like I said, it's very different than a lot of conditions where it's like, oh, well, this muscle's weak, we just gotta make it strong. It's like, not quite. It's like, no, this muscle is actually strong, and it's fighting another strong muscle, you know, which is a whole nother animal, you know. And so we actually have a video of my physical therapy. I was hoping we could show that. Do you have that? All right. Yeah. Yeah, I've been doing physical therapy, like I said, for close to 20 years. It'll be 20 years in September. And I still go to physical therapy twice a week. It's basically 3 hours a week. And then, yeah, it's called a Locomat. And so basically what that machine does is it uses biofeedback. So it's what they call a cobot. So it's like a robot that you're cooperating with. And then I'm doing weighted marching. So I got 5-pound ankle weights on each leg and marching. You see that? And then obviously that's, so when I do exercises like that, I focus on the eccentric a lot. And actually the real thing I'm focusing on there isn't so much building strength as it is actually keeping my knees apart. So as I come down, I know it's, we can go back, I'll explain it, I'll let you guys just watch it and we can go back to that. I can explain why I do what I do.
Good to see.
Yeah.
Starting to.
And that's me walking with my dad. So he always has to walk behind me so that I don't fall. By the way, I'm the opposite of most people. If I fall backwards instead of forwards because of the extensor tone. So you'll see I have like a lot of heel whip, and then this shows it better. Actually, see, walk with the crouch gait. A lot of adductor hamstring tightness. But I can walk pretty far distances. I do laps like at stores, so I do the perimeter. I just go around multiple times. And I have a home exercise. I have like a whole gym at home, pretty much. I actually used to have more. I used to have parallel bars. I used to have a whole mat table, everything. There's some more of me walking from the front. So yeah. Well, yep, it's at mine. And in fact, that's the same wire that this happened at, by the way. I go there on a weekly basis. It's kind of a weird feeling, but yeah, I do. And then, yeah, like I said, like my muscles actually aren't weak. Like they're just not coordinated. And when I'm doing these, like I was saying, I focus on high repetition. So I keep the weight low and I just rep until I can't rep anymore. Usually for the last rep, I hold it with an isometric. With that, I'm actually focusing on eccentrics. So as I come down, like you'll see I'm trying to actually slow it down. And here's like an arm bike. When I first started exercising, like it was always with like machines because they guide you. You know, like that's a cable machine there. Working my rear delts. So yeah, there's some examples of like my physical therapy. It's not exhaustive. I mean, I do even way more than that. I wish I had some video of me in the hydro track. So like years and years ago, I used to go do this thing called a hydro track. And basically what it was a treadmill that was submerged in water, which was really cool. But it chews your feet up. So I had to wear like special shoes in it, which then they catch on each other, and then it defeats the purpose. And it's just, yeah. So, but yeah, hydro tracks are really cool, but they don't last very long because of their mechanics. They tend to break frequently because water and chlorine are kind of the enemy of electronics. So yeah, it's a great device when it works. So yeah, so my physical therapy goals are to be able to walk independently. I mean, I can walk, but I would like to be able to walk independently, moderate distances with my walker and leg braces. I would like to actually eventually be able to use a manual chair instead of a power chair. And there's a few reasons for that. But the main reason is that transport vans are really expensive, and this chair weighs 500 pounds. And so you can't get like a normal car and, transport this thing. So, you basically have to spend BMW money on a minivan, which is double injury. I mean, it's one thing to buy a minivan, it's another thing to have to, pay like a college loan every time you buy it. So I want out of this thing. Even though this thing is like more comfortable than a manual chair, it's a financial doom-baggle, So yeah, to be able to do a manual chair is one of my goals. And like I said, so like all that pressing you saw me doing and like that rowing stuff, like that's so I can eventually do a manual chair. And I've got the strength to do it. Basically, the only two things stopping me at this point from converting to a manual chair is I still need a little more range of motion to reach all the way back so I can get a full push. And I need a solution for my left hand. So one thing I failed to mention is that my injury is somewhat asymmetrical. So like it did affect both sides, but more severe on the left than the right. And so my left hand is basically clenched all the time. It's very hard for me to like open it very much. And so to be able to push a chair, you have to be able to grab the bar and like do that. But now they make these things, they're called nubs. So like I could just like hit it with my fist pretty much. So hopefully that's going to be a solution to get around the fact that I can't really open that hand very good. I do have something at home. I couldn't find it, but I used to use it quite a lot called a Sabo glove. I don't know if you guys know what a Sabo glove is, but I used to wear it on my left hand, and it has like rubber bands that basically attach to your fingers and it like pulls them open. And so like it keeps your hand in an open position all the time, and all you have to do is close it. And if you can tell it to relax, bands will just automatically open you back up. So they call it a Sabo glove, and it's a total pain to put on and off, but it does work quite well. The thing is that gloves are really hard to get on even for normal people. When someone else is trying to get it on your hand and your hand is not cooperating, like the fingers bunch up, and I wish it worked better because it really is like a lifesaver when it works. It just takes like 30 minutes to put it on. So yeah, you're starting to see that there's a pattern of like, there's a lot of things that work, they just don't work quite well enough. So if a lot of things could be like improved a little bit, like just a little bit, like it would make a big difference in my life at least. And then like I already talked about, reducing extensor patterns and just creating more general independence. Because like I can do so much for myself, but like because of the lack of like muscle coordination and range of motion, like a lot of times like it's hard for me to like finish certain things or start certain things. Like I'm like a middle guy. Like I can do all the middle stuff, and sometimes just getting it started or getting it finished, that's like really difficult for me to do. So just being able to like complete tasks 100% without any help is, something I would like to be able to do. But I'm not like fully dependent on other people. It's just, for certain aspects of it. And then yeah, these are my socials, and if anyone's got any any questions,